Hello, everyone, and welcome to this evening's webinar. I'm sure we've been waiting for this moment for a long time, and now we're finally here. Um, However, we would like to wait for like maybe 2 minutes so that more people can join us, and then we kick off. We have a lot on the lineup for us this evening, so yeah, let's just give 2 minutes grace to those who need to sort one or two things out and join us. All right.
A few moments later.
All right. So here we go. Once again, good evening, everyone, and well, good morning to those who may be joining us from some other places around the world. As you're all aware, we're about to have a webinar about research. Yeah, and we have quite a lot on the lineup for you, like I said before. So, the title of our webinar is How to Start a Medical Career in Research. Please get your writing materials and get set because the plane is about to kick off. All right. Like for those who are in our group chat, the medical doctors who are connected, I told us earlier on that there are so many things that we can benefit from this. Number one, um, when you participate in something like this and you take research very seriously, you can actually get a professor that could sponsor your master's degree abroad. You know, you can get what's called research assistantship. And apart from that, if you really take your research very seriously, your name actually goes out there and you may be invited to come and present a paper abroad and things like that. So there are so many opportunities and benefits that are connected to this, and I'm sure Dr. Faithful is going to give us way more information on this. So yes, without further ado, I would like to welcome Dr. Faithful. Dr. Faithful, you can have the floor now.
All right. Good evening.
All right. Good evening.
Can you hear me?
Can you hear me? Yes, we can hear you.
All right.
All right.
We're here to talk about how to begin a career in research, and I think that it's timely. And every now and then, ever so often, I get questions about how do I participate in research? How can I join your research group or your research team? How can I also get publications? How can I begin academic writing? When did you start? How come you're always announcing papers every now and then, and so forth? But then I think that then one can assume that the idea of research is not lost on anyone entirely. People do research for different reasons. Um, yeah, reasons best known to them, but at least there's a general consensus as to why we do research or why research is relevant in the first place. Um, as a background, research can therefore be summarized as any attempt to find answers to a question. What, how many people are hypertensive in a particular class? How many people are hypertensive in a particular community? How many people have diabetes? Or amongst persons aged 40 and above, what's the proportion of them that are diabetic? These are questions. And our attempt to answer these questions, one can say, finally put, is research. However, the way we go about answering these questions is what differs, and that's what gives birth to the methodology. So our methodology, the methodology we apply will obviously depend on the question or the hypothesis. That's the assumption that we're working with for the purpose of our research. But whatever it is that we're doing, it must follow a scientific approach from the hypothesis stage down to where you get your thesis. So the methods must be standard, must be unbiased and universally recognized. I know that for some or for most, the interaction we've had with research writing or academic writing, maybe what we did in our undergrad, that is for those who had a research component as part of the course requirements for their undergraduate course or undergraduate program. How big, when, if I allowed to build from there. Building, that's writing research for undergraduate program. Most of them we had see students having to go into communities to collect data and then write up their results and then discuss their findings. As what we'll come to find out later is what we call original research, because you're working on primary data. In the original research, there are different types of original research depending on the methodology that you are using. But if I to start a career, a research career, maybe as a medical doctor, as a medical student, as a medical laboratory scientist, pharmacist, whatever profession, as far as you're in the healthcare system, do I have to collect data? That is a recurring question that keeps on coming up every now and then, or ever so often. The answer is no, because there are different types of research. There's primary, there is secondary data. And it's much more easy and convenient for us to use secondary data so that we can take out the need to go into the field and actually collect the data. But the problem, the question that we must answer once again is the kind of question that we're asking. If we're asking for currents, if we want to know how things would look like in the future, if we want to compare two different groups or two different categories, then one would assume that we can only do that by an original research or original study. When I keep using the word original, it's not that one is fake and one is less original or unoriginal, but it's based on the data, whether it's primary or secondary. So I said that it must follow a scientific approach from hypothesis to the thesis. So the methods must be standard, must be unbiased, and universally recognized. So your questions can be about the problem, for instance. How large is the problem? What's the burden? What's the scale of a particular disease? How common is it? How prevalent is it? Who are the persons who are more affected by this? Is there a way to predict risk? These are research questions, possible research questions. What are the predisposing factors for a particular condition? How can the problem be diagnosed? What are the effects of this problem? What are the interventions for it? All right. So we can also have research questions can also come up from your observations that you've made over time. Recently, we had one of our work that was published on HIV/AIDS and its effect on reproduction. That's for females. That's talking about amenorrhea. So a few of us, as doctors in our clinical practice, made an observation. And what was the observation? We observed that patients who were living with HIV, upon presentation to the clinics, for females, it was quite common for you to have them complain about secondary amenorrhea. Ever so often, they tell you that their period is infrequent. Sometimes they go months without any period, and then other times when it occurs, it's scanty. And this is even before they attain what is expected for their age and for their race for menopause. And it got us curious as to, does HIV in itself have anything to do with amenorrhea? Does the antiretroviral therapy that they take, does it have anything to do with amenorrhea? A research question has come up just from our clinical observation, and then we'll strive to answer the question going forward. So we'll have to now decide, how best do we address this question? How best do we tackle this question? So you can also have questions come up from literature that has been reviewed. So when you do a literature search on maybe Google Scholar or PubMed or whatever other database that you have, and then you do a quick scan of papers on a particular topic, you go through their abstracts as a summarized part of the paper, you see that they often leave or state their gaps around the conclusion. So we found out that this is the prevalence of hypertension. However, we think that future research direction should be on this and that. So those recommendations for future research directions can form the basis for your research questions, something that you may want to answer on going forward. Sometimes it can be topical issues, like an outbreak. It's a problem currently in Africa. DRC Congo is most affected. The African CDC has been on top of the matter. What is mpox? Should we be bothered? Should we be concerned? What are its implications for health security? What are its implications for pandemic preparedness, so to speak, both in terms of Africa and the entire world? What is the state of vaccine development? What is the state of vaccine availability? What is um, um, what about how do we prepare to tackle mpox using vaccines when COVID-19, if anything at all, it set us back when it comes to vaccine acceptance and uptake rates in our communities to an extent where we're now seeing an increased prevalence for incidents for vaccine hesitancy and vaccine misinformation. Albeit these things have always been there from infection. You see, so many questions already have come up from mpox. From mpox itself as a infectious disease, down to state of preparedness, down to pandemic preparedness, down to vaccine development, down to vaccine hesitancy and misinformation. These are research questions that can be answered. Anybody can come up and work on them. Okay, it can also be as a response to a call for a publication or grants. Oftentimes, you see some journals advertise calls for papers that focus on particular niche areas, and then therefore you can work with your team to try to develop or set up a research question that's focused on addressing the particular interest that the journal is seeking, or maybe a grant that has been advertised. Or sometimes it can be as a result of you working on a particular research area or working on a research question that seeks to answer questions for a specific challenge or brainstorming session. What am I saying in essence so far? Every research must have a problem that they aim to address. The problem could be a gap of what is known, in what is known rather, about a particular subject, or a foray to explore existing challenges. So then you have the research question, and then you frame your research title. However you want to put it, sometimes we even write papers and then we work on the title much more later. But while you are beginning your research process, I think that you want to get a working title. So research titles basically follow a DDO approach. That's your domain, the determinants, and the outcomes. That's sometimes mostly used for regional research. So I'll just briefly run through it. Domain, things like the symptoms, disease, or health-related events. The determinants will be things like the risk factors, correlational factors, testing modalities, treatment modalities, and what have you. And then outcomes, still maybe a disease being an outcome, uptake rates, mortality, hospitalization rate, and recovery rates. Your research question can also be developed using the PICO framework. That's your patient, intervention, comparison, or outcome. But like I said, this needs to typically follow your original research or when you are drafting your thesis. So I'll just move swiftly on to the next. Now, in types of research, we have a few types of research intervals. It can be a letter to the editor. It can be a communication. So oftentimes referred to as short communications. We can also have a case report or case series, case control or cohort studies, reviews or book chapters, randomized clinical trials, review of literature. It can be narrative reviews or systematic reviews. How are all of these things different? Letter to editor. This is a very simple type of paper, but it's not so simple. But it's down there in the hierarchy of evidence. There's a pyramid. You can Google it later on, called the hierarchy of evidence. We don't follow it dogmatically because at the end of the day, what informs what you're going to use is, again, the methodology that best answers your question. So a letter to editor is basically a short piece that is written as an address to the editor-in-chief of a journal. Okay, sometimes they are not peer reviewed. The editor just reads them and then decides on whether or not they are relevant to the literature, the body of literature, to the journal's focus. Other times, letters to editors are relevant to scientific body. The scientific body obviously need to be peer reviewed. What is peer review? Now, peer review is basically the idea that as a scientist, as a researcher, you want to contribute to the body of knowledge, and therefore your work has to be vetted by peers, your peers. You know, the US, for instance, the justice system has a jury. They have a jury system where you are tried by a jury of your peers. Okay, people that are like you, your equals, maybe the same research area or research domain, that are quite conversant with what you're doing, with what's new, what's been there, what's existing, what's ongoing. So they'll be in a better position to like criticize, recommend, improve, or advise the journal whether or not to reject your work, to accept your work, or to accept your work with revisions or corrections. So the letter to editor is addressed or tailored to a particular journal, the editor-in-chief. They're very short. Sometimes some journals say 500 words as the maximum. So you can see that it's just basically like a very short essay. Other journals like Lancet may say 400 words. Nature may say 300 or 350. So you have very little room to play around with words. Every sentence, every paragraph must count. And in what instances can you write a letter to editor? Most times, a letter to editor is written in response to a journal when you want to bring to attention certain things that you've observed in a recently published work. Let's say you were going through maybe the Nigerian Journal of Medicine and they just released their November edition or their October edition, and upon reading, you come across a particular paper that intrigued you, and when you read it, you saw their results, and you have questions. Either, oh, why did they this method that they use? I think there must be an error somewhere. There might be a mistake somewhere. They could have expanded it to this. This is why you are a scientist, a researcher, a clinician, whatever it is. So you can actually read papers and have input or feedback that you want to give. So letters to editors, most journals reserve it for as responses to recently published works or papers in that same journal within that particular year. Some of them even have time restrictions that you have to be a number of months okay, for you to respond and reply. So you obviously see the letters to editors according to question in this particular paper that was written by this. While they did this, their methodology, however, have certain questions about what they did here or what they didn't do here. Or I think that from this particular, okay, there are sometimes that people can make an observation and then you notice that while you're about to go into your study, maybe you want to do a study on gambling among undergraduate students, and then you're expecting that those who are in the lower socio-economic status or strata, they will gamble more because they don't have enough money, and then they are trying to make more money to be able to cope and afford life as undergraduate students. And then you carry out your research, original research, you collect your data, and when you analyze, you're finding out that those who are better off or higher socio-economic class are actually the ones who have a higher tendency to gamble or to bet. And you are trying to explain it by saying that possibly because these students are in the higher socioeconomic class, they have much more access to disposable income, and therefore they are using their disposable income to afford sports betting or gambling. Okay, and then you give that as an explanation, and somebody picks up the paper or picks up the literature, and then has a better explanation for the result. You can write all of that in your responses as a letter to editor, to the editor, LTE. Now, in other instances, your letter to editor can be used to call to attention the journal for topical issues that are quite pressing and may not need the time to go through a rigorous process of peer review. That is for journals where the letters to editors are not peer reviewed. So short and captivating. In other times, letters to editors are short, powerful pieces that need not go through the methodology of having to maybe review a lot of literature or carrying out original research. And so you just pick bits and pieces addressing a particular question, a particular need that you think is topical and quite relevant to the journal, and therefore you raise it up or you flag it up. Let us say Mpox. Okay, Mpox is okay. Malaria. Nigeria is about to receive 1 million doses of malaria vaccine to roll out this malaria vaccine program. And then you are wondering, malaria, Nigeria has the highest burden of malaria disease. The vaccine program, malaria vaccine, has been available in parts of Africa for years now, and Nigeria is just joining the program and will be a beneficiary of 1 million vaccines. Is there any concern about acceptance rate for this vaccine? Do you have concern that there may be abuse of the process, there may be issues with dissemination, there may be issues with misinformation, or maybe even corruption, or something along the lines of maybe adults wanting to take the vaccine when the vaccine is ideally for children who are under 5 and pregnant women who are most at risk for that from dying from malaria? And then you can raise up these questions and try to point the body of science, people in that research area, or even the general public to a particular issue or problem in a very few words you have got in your letter to the editor. So all of these instances are examples where the letters to the editor becomes relevant in your research as a research endeavor. So I'll quickly give an example. I will have one here. So what do we have here? That's a letter to the editor on your screen. The title is Advancing Vaccination Gaps Among Healthcare Workers in Sub-Saharan Africa, the Role of Mandatory Hepatitis B Vaccination. It was published by the Tropical Medicine and Hygiene Journal. They rarely publish letters to editors, but when you make a good case, you are much more likely to get published. So what is the argument here? The argument here, or the case here, is that hepatitis B virus is an infectious disease, one that is even much more infectious than HIV, between 20 to 100 times much more infectious than HIV. So infectivity rates are like 0.3 for HIV, and then you have it being as close as high as 30 for that 100 times that of hepatitis B. That's from previous studies. So you see that even in the process of writing the letter to the editor, you must do a review of literature, although you will not write your review of literature in the paper. Those who have done the graduate work will remember that when they were writing their thesis, they have a number of chapters, their introduction, the literature review, the methodology, the results, and then the discussion section. So that literature review section sometimes is a type of paper. It's a type of research endeavor, which is writing reviews. And then there's a distinction in that, which I'll come to in a matter of minutes, on whether or not the reviews are systematic or not systematic. I'll come to that. So what is the case here once again? Hepatitis B virus, very infectious disease, and it's a significant public health threat. Why? Because it is much more infectious than HIV. That's not the only reason. The second reason is that it's a cause of liver cancer. So it's a vaccine preventable cancer. Is it reasonable that in 2024, 6 years away from 2030, where the world aims to eradicate hepatitis B, is it reasonable that people are still dying from vaccine preventable disease? The answer is no. Okay, and then we now say, is the problem? Is vaccine preventable? What are the vaccine rates? And then we look at the data and we see that there are glaring disparities in vaccination rates between low and middle income countries and high income countries. We see that in sub-Saharan Africa, for example, vaccination rates are the highest, 42%. And then in high income countries like France, it's 97%. That's a significant disparity. One can even explore the particular subject within the domains of health inequalities. It's carried. And then we saw that and we're saying you can't make progress if your vaccination rates are low or your vaccination rates are poor. Mind you, the 42% vaccination rate are not vaccination rates in the entire community. It's vaccination rates within healthcare practitioners, healthcare workers. Healthcare workers, your top is 42%. It's the problem because it then means that for the entire community, it will be much more lesser, right? Now, why is it relevant? Why are we having a distinction between healthcare workers' vaccination rates and the general public? Because we expect that healthcare workers are more inclined to vaccination. Health workers are much more responsive to vaccination campaigns, are much more likely to get vaccinated against infectious diseases. That's one. Two, they are a high risk demography for hepatitis B. much more than the general population. And we see from the data that it's about 10 times the risk is borne by healthcare practitioners by virtue of working in the hospital, especially for those. We now look at also from the data, we see that the risk increases when you're early career, you are an intern, you are a medical student, you are an intern nurse. We see that it's worse, the risk is higher among nurses and interns. That's from data from previous epidemiological research. Obviously, for those kind of studies, there were original studies, primary data. You've done the analysis, and this is what the result is telling you. Now we want to write a letter to the editor, but you see that we've gone back to the drawing board. We've extracted all of these relevant data to make a case. So we are seeing that infectivity, the risk of contracting hepatitis B virus is not actually the same, equal for all populations. It's worse for healthcare practitioners and healthcare workers. Even among healthcare workers, it is worse amongst those who are at the early stage of their career. Why? Because of skill level. When you are beginning clinical practice, either as a medical practitioner, nurse, phlebotomist, laboratory scientist, we see that from the data. Needle stick injuries or accidents are much more frequent in persons who are still beginning their career, and then it progressively begins to drop. The rates begin to drop down from those who have stayed up to 5 or 10 years. And needle stick injuries are much more common than we want to believe. To the extent where the problem we also notice is that early stage clinicians, irrespective of the profession, hardly report needle stick injuries. Nobody wants to be scolded or looked down on in a particular way, and so they don't report it. If they don't report it, it means it's not escalated. It means they may not receive what the hepatitis B anti-immunoglobulin. That is even if it's available. And then we say that the problem with CAT-T is so expensive. Even early career doctors may not be able to afford this immunoglobulin in the event that they are infected or they have a prick with a high risk patient. And we gave examples. We saw examples with one instance where even medical doctors, house officers for interns, depending on the area where you are, the term that is used much more frequently. And then we see that even among these populations, when they have needle stick injuries with high risk patients, and they need the vaccine is not readily available. The immunoglobulin and not the vaccine is not readily available. Some of them have to wait for over 24 hours to procure the vaccines to be sent down through flights, and it comes at it's quite pricey. So it then means that vaccinations are the easiest route for us to tackle the problem of hepatitis B. It then means that vaccination is obviously much more cheaper than HBIG. Okay, and if we are not addressing the vaccination gap, if we're not addressing the 42% vaccination rate among healthcare workers, we'll not be making any progress. Secondly, is that we know the population drags their feet when it comes to vaccination, right? So if we try to increase the vaccination rates for hepatitis B among healthcare workers, we are going to reduce the likelihood of even patients being infected by hepatitis B. It's not always the case that it is the patient who is infecting their healthcare practitioner. Infection can, be transmitted in either direction. So to address this, what are we suggesting? We are suggesting something that is controversial. We're suggesting something that needs to be viewed in the lens of ethics, and that is mandatory hepatitis B vaccination. As much as vaccines are helpful, whenever you say they are mandatory, whenever you say they are compulsory, you prepare for an ethical debate, an ethical dilemma. To what extent does it clash with autonomy? Okay, the freedom of person to make their choice. We are giving patients the power to make choices with whether or not they would accept a particular vaccine. How much more, even healthcare practitioners, you would think that of all persons in the population, healthcare practitioners should be more lean more toward vaccination. But you'll be shocked, especially with what we're seeing with COVID. But then again, we also look at the data. What are the problems? What are the hindrances for these poor vaccination rates? And healthcare practitioners have said the fact that the vaccines are not free, the fact that the vaccines are not always available, the fact that they are shifts. So sometimes they may start the vaccine, take the first dose, when they take the second dose, they find out that what do they call it? They find out that when they return to take the vaccine, they're not on duty, they are off duty. So they skip the dose. The absence of reminders is a problem. What other reason? The fact that the vaccine are not provided free of charge is another problem. So some of these things, how do we tackle stock? Reminders and all of these things. These are some of the recommendations that we'll obviously be making in this particular letter to editor. In few words, about less than 500 words, I think, if I recall. And then we also suggested something else. If we're going to make the vaccine mandatory, how will it be done? So what's the role of the legislative arm of government, the role of the medical and dental councils in the respective countries in Sub-Saharan Africa, the role of the respective medical associations, even the healthcare workers themselves? And we're saying if people are going to commence internship, then they should mandatorily be vaccinated. And we use Nigeria, for example, where some of the researchers, the group, the research team, we say, okay, there's a rule that within 2 weeks, these persons are supposed to be resumed for internship. Let's say this is somebody who has not been vaccinated as well for hepatitis B. What's the solution? And we're saying, okay, you take the first dose of the vaccine. The routine dose for hepatitis B is first dose 1 month later and then 6 months later. But then, in the course of our research for this particular paper, in the course of our writing, we share to the public, we share to the scientific community that there's an accelerated dose of hepatitis B vaccination. That is first week. And the first time you take it day 0 in 1 week and then in 3 weeks. So in 21 days, you're able to have given the patient 3 doses of hepatitis B vaccine, and then they will take a 4th dose after 1 year. And with HB titer being assessed in these patients, you see that they are immunocompetent for the hepatitis B vaccination. So how can we share that is one of the reasons why you are drafting this particular paper. Letter editor is short, it's fast, you write it and you put it out there. This actually came, I conceived it while I was working at my previous place of work, and hepatitis B vaccinations were compulsory there, I think, before you are deployed. And one of the reasons is because of litigation to avoid exposure, especially legal exposure to the company. And then I said it makes sense, but why is it not done outside? You know, the private hospitals, so the tertiary hospitals, public facilities, and then reading more of the literature. These questions now arise, and then you put it all together, and this is what you have: a beautiful piece, a letter to the editor. Okay, to the editor. All right, so I attached the link to the paper. For want of time, I just want to move. So we have what we call a perspective paper. A perspective paper can, in some journals, be a commentary, but this basically depends on what the journal is focused on. Let me cast your mind back to for have sorry if there are medical students who are yet to be final year here. But if you've done an undergraduate work that had a thesis as part of the works that you part of your degree, certify your degree requirements, then you must have done an original research. And then you would have realized that you are told that you should cite everything that is not your words. And then you also realize that the extent to which you use your own words and thoughts is quite limited. In the literature review, you are basically reviewing what has been said in previous literature. You're trying to use certain areas to discuss the subject matter. You frame the way it flows based on the research objectives that you have, and then you move from there. In your discussion section, you are basically trying to discuss your results and tie them within the context of existing literature. So there's a limit to what you are saying. In your there's a limit to what you say. Your systematic reviews too. But there are certain types of papers that allow you to share your own thoughts, your own ideas to the body of literature. At least it's not lost on you that the letter to editor obviously is one of such kinds of research papers. Because the letter to editor is predominantly your thoughts, your ideas, and then you're just basically picking up to support your arguments or strengthen your arguments from the literature. All right. So in the perspective paper, the perspective paper may be a much more larger paper, a much more longer paper, but it allows you to extensively discuss a particular subject matter through headings that you may choose to come up with. It's almost like a review of literature, but you are sharing your thoughts, your ideas, your perspectives on a particular matter. I mean, it's so obvious this particular paper is captioned the perspective on the novel pentavalent Men5CV meningitis vaccine and Nigeria's pioneering rollout campaign. When we wanted to write this paper, we realized that in 2023, Nigeria was facing a meningitis outbreak, as well as some other countries. In reviewing the literature, you then realize that there are certain parts of Africa that are termed as the meningitic belt. Regions around where meningitis as a problem is quite prevalent, about 2.5 million cases in that particular region. It's quite alarming and it's quite a problem. So Nigeria has made significant progress earlier on when it comes to meningitis. We've had, I think, the quadrivalent or trivalent vaccine, Men A vaccine being given up north, where you have meningitis outbreaks. The serotype was the serotype A. That's what was common up north. But then we now notice that in 2023, the outbreak was a distinct serotype and not the serotype A. So the Men-Afrivac vaccine that we're using could not help the situation. Earlier on, they were pushing efforts, advocating for efforts to get vaccinated up north, but they were vaccinating people with the Men-A vaccine. But those who knew that the outbreak is not caused by serotype A. Therefore, the vaccines that you are giving to people will not protect them against this particular variant of meningitis. But then they say, to the extent where I mean, it will protect against serotype A, as serotype A was a problem in this particular region. Let's just protect against something. It's just like the situation we have with the snake vaccines, where you have or immunoglobulins given to patients after snake bites, where you know very well, pretty sure that most for hospitals or facilities that have those groups, the strains that are available will not, in most instances, address the particular things. Like, I mean, they are quite restricted, like the range for the kind of toxins they can address. But you have them purchased by some clinics, nonetheless. And then you obviously cannot buy everything. So, in the event that somebody really has a poisonous snake bite that will actually need to be treated, to be managed with the antitoxins or antitoxins, you realize that what you have in your shelf will not be sufficient to address a particular problem. The veterinary research institutes, where they do extensive research on laboratory research on formulations for anti-venoms and all of that, are in a better position to maybe look at the picture of the snake and then go through their catalog that they have available. And then you obviously see that in most cases they have an antitoxin that can address a particular one. But it's different from most of these shelf products available in certain centers. But we keep them in our cupboards most times for ethical, legal exposure. It should just be there. It should just be available. So what is the story? The story is that a company in India began research and extensively started developing a pentavalent vaccine that could tackle 5 serogroups of meningitis. And they released the vaccine. And the first country to adopt that vaccine was Nigeria. And with 1 million doses, we started the vaccination. And we got a grasp of it. There are certain persons not in the southern part of Nigeria who never knew that Nigeria was battling a meningitis outbreak up north. So that is why you do research. That is where this comes in. So this is a kind of a literature review, but a perspective review. So it's a perspective on the pentavalent vaccine and then the rollout. And then we look at meningitis, the burden of meningitis, the development process of the vaccination rate, vaccination, the results from clinical trials, and even things like how it will be accepted in the communities. All right. Okay. So moving quickly on narrative reviews. So narrative reviews. In reviews, you are basically reviewing literature. You are synthesizing literature. But it can either be systematic or non-systematic. So what is a systematic review? A systematic review is one who uses the PRISMA guidelines. That's the preferred reporting system for what systematic reviews and meta-analysis. You can Google that up. PRISMA is PRISMA. So the PRISMA guidelines basically states how you should go about it. You register your systematic review or meta-analysis online so that another person doesn't start working on similar project. And there are certain criteria that need to be met, so that before you commence your systematic review. And then when you, let us say you want to review a systematic review of the prevalence of hypertension in Nigeria, every small center have done some study on hypertension in Nigeria. Medical students have done, resident doctors have done, fellows have done, professors have done. There's a lot of work out there. And now you want to get the true, what is closest to the true prevalence for the Nigerian population, to such an extent where it is not possible for you to do sample the entire Nigerian population. So there's some study done in Ondo State, or your state, in Rivers State, in Abuja, but you want to do a systematic review of. So you put in your criteria, you put in your, when you want to do your original research, you have your research objectives. From your questions, you also have your, what do they call it? What do they call that thing? Where you have to decide who can participate in the study and who cannot participate in the study. Why am I forgetting it?
Exclusion criteria.
Yes, thank you.
Inclusion and exclusion criteria.
Yes. So in your original study, you have inclusion and exclusion criteria. In a systematic review, you also have inclusion and exclusion criteria. The kinds of papers, the kinds of research that you want to include in your systematic review, and the kinds that you want to exclude. So in a systematic review now, for instance, for the prevalence of hypertension, you say something along the lines of papers that are studies that were conducted in Nigeria. That's one. Two, you say they have to be original research. That is, primary data was collected. So you don't go and review a review. In some cases, you can review reviews. But most times the standard is a systematic review. You want to eligibility only papers, only research that was original, primary data that somebody collected data for this particular thing. And then you now say papers that are in English. So if it was in French in China, you don't want to use those papers. Then you can also say something along the line. That means you want to exclude things like exclude things like case reports, narrative reviews, other systematic reviews, or what have you. What is the idea here? The idea here is that you want to get papers where they at least got the data from different places. You will now get a table, a spreadsheet, author, original, the author's name, the title of the paper, what kind of population did they work on. This paper worked on prevalence of hypertension amongst market women, among school teachers, amongst medical doctors, amongst medical students, in the general population, among civil servants. You see these kind of things, right? So you want to spread out all these things on your table. Okay, then what are the research objectives that they had? Prevalence of hypertension, whether or not they are on treatment, whether you understand those kind of things, follow up to treatment, whether they developed some cardiac issues, whether they developed all of these things. You spread it out on your table. And then you begin, if you are now focused on prevalence, then you begin to insert and try to do, you may decide to add, there's systematic review and there's meta-analysis. Meta-analysis is an analytical part, where the prevalence of a particular study, of a particular condition, in different, the papers is different, right? So your data analyst has a way of working it and getting what you would have called a pooled prevalence using advanced statistical methods. But for your data analyst to do a meta-analysis and generate the pooled prevalence for you, it then means that the populations from your systematic review has to be identical. So you cannot have papers are very greatly to an extent where some papers are talking about prevalence of hypertension in people who are above 70, and then others are talking about amongst maybe students. The populations are not exactly alike, so it may be difficult for you to make exact comparisons or inferences from it. And so you may just go ahead to review and say, okay, the mean prevalence from 5 studies that were included in our study is this. The median is this. You understand? The upper limits, lower limits, and use all those statistical terms to explain. And then in the pyramid of evidence, which I said you can go and check on, you see that up there is randomized control trials and systematic reviews. Your systematic reviews are given the highest form of credence or relevance when it comes to research in the scientific community. If you do a systematic review on prevalence of this, it's irrelevant. If what you say from your systematic review, you have 56% as prevalence of hypertension in Nigeria, that's what I will use. That's what should be cited. That's what should be taken moving forward. Whether somebody got 40, 36, 31, no. The systematic review, the results, is the most standardized, is the most rigorous, and the most systematic. Why are we calling it systematic? We're saying because if somebody were to see your methodology, go through your methodology, they will get the exact same results. If I were to write a narrative review on the prevalence of hypertension, I am going to say sometimes I may try to be as systematic as possible. When you want to make your narrative reviews, increase their chances of being accepted by top journals. So you try to be as systematic as possible, employ a systematic approach, but it's not a systematic review because number one, you did not register it. You did not use Prisma tables. Sometimes we even use Prisma tables for narrative review, but we don't go all the way with satisfying all the requirements for systematic review. But we don't use the Prisma table now to make the narrative review, much more nice, understandable, relatable, and relevant to the scientific body. Okay, so then I say the papers. From the search strategy, how you get the papers in a systematic review is systematic. So you are going to go on PubMed or you are going to go on Medline, and then you type hypertension. And so, or there are certain keywords that brings us into a different area of research entirely that has to do with research strategy. keyword analysis. It's a different ballgame entirely. So on PubMed gives you a smaller version of Medline. Medline is the repository of anything that has been published with academic literature. So in your research, you see that some papers, once you look at the abstract, they know that you have keywords. They say put 3 to 5 keywords, some even say up to 7. So so sometimes you see students when they write undergraduate work, they come up with keywords by themselves. So this is a study on the prevalence and correlates of medical student misspelling in Nigeria. And then I may say the keywords are mistreatments, students, prevalence, correlates. No. If you want to be a little bit standard with your keywords, then you will copy your abstract and go to mesh. Mesh is M capital small letter E capital S and H. So mesh is medical subject headings. Okay, so we call keywords that are generated through mesh as mesh keywords. You go on PubMed, when you paste the abstract, it will generate your keywords for you, and then you can select the file. So that if somebody is doing a systematic review and they type those keywords, your paper will come up. So when people want to do systematic review, your search strategy, you is available. Somebody else will carry it and it will give them the same number of papers. What's the idea? The idea that you want to search for papers. If I tell you now to search on prevalence of hypertension, there's Ikakita here on this call. And then when you search, you may bring 24 papers and say, okay, yeah, I thought I got my results. If I tell Godwin may get 12 or 15 or 30 or 80, depending on the method that they use, right? In that instance, your search results are not the same because the search strategy that you employ is different. If somebody who knows what they are doing goes and picks up Medline, first things first, not everybody has access to Medline. Because for the larger FS, you need institutional access, your university access to affiliate with the university to access Medline. And so when you go to Medline, you type hypertension. You now have what we call what are those words? Okay, in syntax, you can say and prevalence. If you say and prevalence, it means that what will be the outcome, the results, are papers that have hypertension and prevalence. If you say hypertension or prevalence, it means that you have papers that have either hypertension or prevalence. So if you search for these two things, if you do hypertension and all the papers you'll be seeing are papers that contain prevalence, hypertension, prevalence, hypertension. If you say or, you may see prevalence of gambling, prevalence of sickle cell. You understand? So you cannot have people write hypertension and prevalence and Nigeria. So if you do these three things, you're going to have papers that have hypertension in them, prevalence of hypertension, and about nation Nigeria. But you want to expand it to your initial stage, so you may do hypertension and or prevalence and or Nigeria. You understand? This is how you mix it, your keywords at any length, and then you put it, and then you search. It will give you on Medline 3,000, this paper, 108,000 results like that. See, you code it down to exactly what you want. Your final result will now be 115. You copy all your search inputs and then you paste it and keep it somewhere. If somebody follows what you did, they will get the exact same number of papers. Okay. In that instance, we are saying that at the end of a systematic process, you get the same number of literature so that you don't end up skipping something that is relevant. If I did a narrative review and it follows a non-systematic approach, so I'm just going to say we'll go to Google Scholar and we'll search for hypertension, prevalence, and all that. Then we'll go to PubMed and then I may do hypertension and prevalence and Nigeria. And okay, how many papers did they give me? Maybe I go to AJOR, that African journal database, I go and search. Okay, and then maybe I may go to Chinese database. I go to different databases and search MBAs, and then by the time I'm done, I have maybe 140 papers. And then we now use 140 papers to now screen them, whether or not they are relevant to the objectives that we have and all of that for the review that we want to do. Only to realize that if you had followed the systematic approach, you would have gotten maybe much more papers or much less papers. But in the narrative approach, is just basically what people were able to search and what people were able to find. So we can share it and say, okay, 5 of us, you pick this, you pick this, you pick that. And then by the time we search, we just compile everything in a list and say, okay, these are the papers that we are going to review that are the results of our search. So it may not be comprehensive. And we say there a non-systematic approach has been employed. And then the next thing now is to screen the papers. You look at the abstract. It is a result of hypertension prevalence, but do they have what you're looking for? No. So you may say that you may want to focus on the review on papers that focus on hypertension in people who are 40 years and above. And so therefore, anyone that the population is not on 40, you remove. You may want to say you want to check papers, including your inclusion criteria, papers that talk about prevalence of hypertension among people that do not have complications. So if you are having papers that are talking about those who are not having cardiomyopathies, heart failure, and all of that, you exclude them. You exclude such papers, right? That is how you're now moving. You are screening your papers. After your screening, you now have the final selection. Sometimes when you search through different databases, you may see 27 papers from Google Scholar and see 34 from PubMed. You don't just do 27 or 34 and say together. You see that some papers are available on both Google Scholar and PubMed. That's if a particular journal index is indexing PubMed, indexing Google Scholar. Let me just quickly mention what is indexing. So there's a journal. A journal is the company or the organization that publishes your work. Let's say the Nigerian Journal of Medicine. Let's say Doctor's Lounge has a journal. Okay. Now, for them to run a journal, they need a publisher. A publisher can be Nigerian Press. And Nigerian Press, they are the ones that publish for Doctor's Lounge Journal. They're the ones that publish for maybe Local Doctors Journal. They're the ones that also publish for the Nigerian Medical Association Journal. So these are 3 different journals. And then maybe there's a publisher that basically provides the infrastructure used to operate, either digital infrastructure or print. Now, there are databases where people can search for literature. The question is whether or not your journal is indexed on those databases. Reviews and narrative reviews. So You try to be as systematic as possible, employ eligibility criteria, and even your search strategy is quite systematic. So the idea basically is that you obviously see that a systematic review is much more intensive, methodological, and methodical. Okay, and it's an intensive endeavor. It will take you time. So, but there are other reviews that are much more easier for you to do, less complicated. Your narrative reviews. So basically, you want to review literature where you just search, you try as much as possible to be as detailed and robust as you can be. However, if you see 26 papers, fine. If you see 14, fine. If you see 50, fine. How then are you able to now synthesize the information from all these papers and get specific themes that they are talking about right on these themes in a narrative way as you would do a narrative essay or a discussion section of your paper? That is the idea of a narrative review. So what you have on your screen is an example of one where we talked about the prevalence and correlates of medical students mistreatment in Nigeria, a narrative review. We could have done a systematic review for this. In fact, the reviewers of the particular paper for this journal, they told us, you have done a good deal of work. Why didn't you guys just go ahead to do a systematic review? And we said we were working on it. We'll actually pursue a systematic review subsequently, but let's just get done with this as a precursor. Okay. But actually, we shelved the idea of doing a systematic review, and we decided to do an original research. Went into the field to collect data, but we decided to do a national survey of sorts. So a multi-center study where we recruited medical students from 12 universities in Nigeria, both public and private, to try to see the exact and true prevalence, the true correlates. And then we expanded the scope based on the recommendations that we saw. You know, when you write your review, anybody you write, you have to leave suggestions for future research directions, okay? And the existing gaps. When you are about to start, you highlight gaps, the gaps that form your questions. But then, even when you are finished and then you've discussed, you can identify gaps, need for longitudinal studies, need for current appraisal of this, and all of that. So when we did our narrative review and we said, for papers that are focused on medical student mistreatment, the prevalence and correlation, we found out that there were only about 6 papers in Nigeria that have just been written, and then we went ahead to town using specific subheadings to discuss them. Okay, so we're talking about the prevalence, we're talking about the correlates, what are the factors behind medical student mistreatment? Is it your level of studies, your level of class, is it the school that you are in, is it whether it's public or private, is it based on your social demographic status, is it whether you are male or female? And then we went into other things that trigger it, things like um okay, things that trigger it, that expose you. Who are the people who are actually mistreating? Okay, is it the consultants, is it resident doctors, is it your fellow medical students, is it family, is it friends? We went into who gets the brunt of mistreatment, is it male or female. We went into what are the consequences: alcoholism, depression, withdrawal from school, using drugs, coping mechanism. We went into reporting. Okay, who do we report to? What are the percentage of students who report the incidents? Do they report to their fellow classmates, to their medical association, to consultants, to residents, the head of department? We went into even checking for papers that talked about the satisfaction of these students when they've reported, whether or not they feel like the report is in vain, or so to speak. So these are the things that this is the reason. I can't recall everything, but the link is available. Those are the results that we got from our paper. You can Google it too. Prevalence and correlates of medical student mistreatment in Nigeria. The narrative review is also available on PubMed. Okay, and now from there we've gone further to launch the original research inquiry into medical student mistreatment. Okay, I just want to a case report. Initially, I thought we have case report and we have case series. The difference is that in case report, you are focused on a particular case. In case series, you are focusing on a number of cases. What is a case? A case is any observation that you think is interesting to the body of science. It can be an adverse drug interaction. It can be something that is uncommon. It can be something that is surprising. It can be a rare disease, a rare presentation. It can be even a successful treatment outcome that you use. It may be popular somewhere else, but it's uncommon where you are, and therefore you write a case report. Think about when COVID-19 came for the first time, uncommon presentation of respiratory illness somewhere in Wuhan. Okay, and then they tried to manage the person. Person died. A few people came and then they died, and somebody writes a case report of a rare presentation of a pneumonia in Wuhan. Okay, and at that time they may not have tested, they may not have seen that it's a variant of SARS and all of that, and then you publish your case report findings. Let's say we have now known that it's COVID-19, and then the world was looking for treatments. There is no cure, there is no vaccine. And then you now hear things like azithromycin is working for COVID-19 with vitamin C. You hear all sorts of things. And then maybe I tried azithromycin for a particular patient and I saw successful success. I can write a case report. It's a rare, what do they call it? Positive result and all of that. But this is the problem. In the hierarchy of evidence, case reports are put at the bottom, at the lowest grade of hierarchy of evidence because they are too anecdotal. And therefore, to a lesser extent, they cannot be extrapolated for the entire population. Okay? Because what worked for that, your particular candidate, is just one patient. Sample size is one. So what is the likelihood that the results are not due to chance? What is the likelihood that there is no bias? How systematic was the process or procedure? So these are the reasons, okay? But then again, case reports have their relevance to the body of science. And in order to standardize them, we now have what we call the care guideline. The care guideline is CARE, which basically stands for case report guidelines or case report checklist. You can check it out. So it's an itemized guideline or checklist that helps to ensure that in reporting case reports, this tautology, they are standardized. You follow a particular process. There is a rationale, there is your clinical observation, there is outcome, there is things that influence diagnosis, whether there are other social determinants of health, the result, the learning points, the outcomes. All of these things you must mention them, and then you go into the meat of the matter, and then do a literature review. Your presentation, what you are seeing, what you are about to communicate, where does it sit in the context of the literature? So before people could just write case report, just report the particular study, we manage the patient for this, and go home. You see that very often in our local journals. You can't try it outside. You understand? So there has to be like an addition, an addendum. Where does it lie in the body of literature? This ties in, this doesn't tie in. When we did this investigation, this is what we saw, this is what previous authors have said they've seen, and all of that. So here is the uncommon yet critical. That's just for finesse. But they basically in here is pulmonary embolism in a 14-year-old Nigerian child, a case report. What's the argument? That pulmonary embolism to some extent is rare in pediatric populations, and it's something, a diagnosis that is much more common in people that are in adults. Therefore, if you have a 14-year-old presenting with pulmonary embolism, there are increased, especially in a country like Nigeria, there are increased chances that you would want to dismiss them. You want to chase something else. You want to say, okay, this particular chest pain and breathlessness in this particular patient may be from another cause. And we basically made our findings. No, it's a beautiful piece, a beautiful paper. So that's it. So what if I see 4 more children or 5 more children with pulmonary embolism? Some years ago when I was doing my internship, we saw a patient. Now, this brings into context relevance of case records. There is the argument of single data really fast. It's at the bottom of the scientific pyramid. Why publish it in the very first place? For those who want to grow in academia, maybe lecturers and all of that, we know that case reports are scored much lower, okay, than other kinds of papers. And practical case. So, I think a 10-month or 11-month baby presents to the clinic with anuria, not urinating and quite swollen. and all of that. And then we discovered that the child has AKI. We are trying to manage that particular patient. We see that the options for dialysis, hemodialysis in town were not compatible for the child's body weight and size. The child could not benefit from hemodialysis. Should the child die or not die? And then we had a very ambitious, very adventurous, forward-thinking, progressive nephrologist then in the center. And he said, okay, let us do the abdominal dialysis, peritoneal dialysis for this particular patient. And whereas it's a common procedure in parts of the Southeast, the truth of the matter is that it will be the first time that PD is done in that particular center. And therefore, you are trying something, you are experimenting something, a therapy, right? You have to look at other literature. You know. Now you're not going to look at original research. What are you originally researching on? Is it on the use, the or what outcome? Or you want to look at the hospital reports? That you have to go to places where they've done a lot of it. You know. So the type of literature that helped us in management of that particular case were case reports that were reported in Delta states, in the Anambra, Southeast, in University of Nigeria, where they reported management of patients with what? Acute kidney injury for pediatric populations that use peritoneal dialysis. In that part of the paper, you'll be seeing things like how they manage the patients. Day 1, day 2, day 3, how many cycles of peritoneal dialysis they did, how they prepared the peritoneal dialysis. Because as opposed to the hemodialysis where you already have your commercialized dialysis, we have to prepare. So we are getting dextrose, we are getting potassium chloride, we are getting heparin, and we are preparing all the constituents, all the electrolytes ourselves. And then we infuse it, run it in, get a three-way catheter and all those things based on case reports. And we saw, okay, this was the dose that they used here, this is how they prepared and titrated it. First 2 days we're not seeing results. Should we increase the concentration? Can we reduce it? When we finish, we'll write our own case report. Is it not it? Excellent. And then now we successfully manage the patient. So we see things like in case report, there's a bias component. Many people will not want to write a case report where there was a poor outcome. You only want to write enthusiastically, write a case report when there is a failed outcome. After this particular paper, I was working on one. I think I've sent it yesterday on truncus arteriosus in a little, very little child. I'm trying to remember the years are old. But the crux of the matter is that there was an unsuccessful outcome in that particular patient. The child went ahead to die, okay, because they didn't have finances for surgical therapy. And where what I remember, there was a line where I said that in the abstract, that one of these things is that this paper shows that what do they call it? Pharmacological intervention is insufficient in managing truncus arteriosus. That's what previous literature says, and this helps to show you evidence practically in River State. You understand, and that's why the paper is what's being published. That's why we think it's important. Okay, and so that's just basically in context, I mean, where the relevance of case reports. And then we have original research. Now, original research is primary data. It can be qualitative or quantitative. Qualitative, where you are not working with numbers or figures, and qualitative, where you are basically not you're not employing a quantitative approach. Let me break it down now. Okay. So you want to do a study where you are searching the prevalence of something. That's numbers, right? So it's quantitative. But you want to get the ideas of medical students and sleep. You can check prevalence of poor sleeping behavior using a yeah, you can employ a quantitative approach. In quantitative approach, you want to now interview them and actually count the number of persons who have poor sleep. You can actually count what do they call it? Yes, poor sleep, the number of hours they sleep. You want to measure it. You want to report your results in means, in median, in percentages. Quantitative. But I can answer the sleep problem with medical students qualitatively. So I can say I want to interview 15 medical students and get their opinions and perspectives through either an interview, a focus group discussion. So I'm going to ask the first person, oh, Ikakita, can you please, will you be willing to consent to this is what we want to find out? And then when I ask, on average, how many times did you sleep in a day? It's looking quantitative, right? And then I begin to ask her, what is your perception of the sleep quality? She mentions, and then she answers. Then I go ahead to say, on a deeper level, how can you like say more about your sleep behavior? How has it impacted your health or your well-being? Then she said something along the lines of, it makes me much more anxious and worried about the day. I feel that I'm not able to concentrate when I go to work or I go to school. And then I interview another person, Elsie, about her sleeping pattern. And then maybe her perception about how it is affecting her. She say, whenever I wake up, I have low energy. I feel cranky and irritable. I feel cranky and irritable. Okay, so that's a particular opinion, and the data I've gotten is not quantitative, it's not in numbers, it's speech, is written. That is what do they call it? It's qualitative. Now, how will I use this? There is qualitative analysis that can be done. There are programs, software programs for it. We have in Vivo and all of that. Now, the idea is that based on the interviews and interviews Ikakita and Elsie, I can now say Ikakita said that she gets anxious, her day is this. This other person talked about concentration. This other person talked about I'm unable to focus. So I can therefore now bring a circle, a thematic area. And the thematic area is about concentration or focus for work and school. Then I may read the interview transcripts of other things I've said. And then I see somewhere about energy. I see somewhere somebody talking about strength. I see somebody talking about weakness. And then I cannot bring a thematic area and say energy to pursue daily activities from my interviews with these students, right? And then from there, I'm not able to analyze their interviews on the thematic area of energy, thematic area on concentration, thematic area on coping, thematic area on things that they think are their solution. And that gives us a qualitative research. It's totally different from what we are very used to. That is, not many people are quite versed with qualitative research and handling, even amongst persons who are postgrads and all of that. Then you can have your observational studies where you can have a quantitative approach. You can employ different methods. You can have cross-sectional studies where you are looking at the attributes in a range of population. You can have a cohort study where you are talking about direction, moving forward. What does it look like? You can have a retrospective study going backward in time. Let's look at the medical reports. Let's look at the history. Let's look at case notes. What does it show us? Okay, and then you can have case control studies. In case control studies, you want to divide your population into two groups. A standard group with similar populations, they serve as your control, and then another population, they serve as your case, and then you check the differences between the two of them, exposure and outcome. And then you can also have your randomized control trials. Randomized control trials are given at the peak of your hierarchy of evidence, almost the same place with systematic reviews. The idea in randomized control trials is that you employ a technique that we refer to as randomization. Now, randomization is different from random selection. When you want to do a quantitative approach and you want to do a cross-sectional study, in selection of your participants, you can say we selected them, we employed random selection. You use random selection as a way to reduce bias, as a way to say that everybody in the population has an equal chance of being selected. Either you are using your coin, you're flipping the coin, or you are using a table of random numbers, or you're using a random number generator, or you're using a software, okay, or you are using balloting technique. All right. Then in randomization, that is an entirely different concept. So In this particular study example that we use here, we had an observational study, was cross-sectional. And what we're looking at the pattern and causes of missed appointments in a Nigerian psychiatric hospital. Okay, so we basically looked at the data and also the records to check missed appointments. What the relevance is that psychiatry is a stigmatized profession. The psychiatric hospital was actually in Calabar, and it was serving about four states and Cameroon. So people actually leave Cameroon, travel down to Nigeria to visit the hospital. If they miss their appointments after traveling like that, you know what it means for their care, long-term care, and keeping and all of that. So those are the things, the motivations, and other things I cannot mention right now that led us to check and carry out this particular kind of study. And I think I've talked about original research, cohort, case control, and all of that. At this juncture, I think I've spoken enough, and I'll be willing to take your questions. Thank you very much for listening. I think that if you are here to start, it's a good point to start. There's a lot to do. There's a lot to research on. There are a lot of virgin areas. Okay, so thank you very much.
Thank you so much, Dr. Faithful. Wow, that was a very well packed one. So many things to learn. I'm sure many of us who probably are new to this, we are like, oh my God, this is a lot of information. What do I do and that and that? But then, actually, what he has done, he has helped to give a very broad perspective so that you know where you are and you know what it entails, and you probably have an idea where you want to kick off from now.